my disclosures. Right, so as has already been alluded to, of course, urodynamics is this complex interplay of the child and their family, the operator, and the machinery, the tests and the traces. And of course, in order to get the answer to the clinical question that we're actually asking, all three of these have to come together seamlessly to create the, to give an answer. And of course, there are various places where things can go wrong. So I just had a little look at a trace at a study that I did recently, and just ringed a few things here for you all to have a look at, just to realize that things don't always go smoothly as you would hope. Firstly, errors. Errors are avoidable and strictly speaking shouldn't happen, but of course we're human and they do occur. So if they do occur, you need to recognize them and correct them. In my defense, here I started this study and actually didn't recognize that the PAB line wasn't working. I was actually very worried about a clot in this child's bladder from a suprapubic line, so I was busy looking at the video pictures before I started flushing and replaced the rectal catheter. You can see in blue places where there are artifacts. Artifacts are events that happen largely unavoidable, but you need to recognize them and characterize them. And then of course there are ambiguities, and in this case here, these rises in PVES, PDET look like detrusor overactivity. In fact, it was inhibited voiding. So you need to describe that and explain it so that it's not misinterpreted at a later date. Smooth changes in traces are generally physiological, whereas sudden changes and spikes are generally artifact or error. So just looking at some examples, here's another error. This is a case where the rectal and the vesical lines were inadvertently reversed, showing these the abnormal trace, and it took quite a while for the urodynamicist to recognize this. This is a common artifact. Here you can see this was actually in a neurogenic case, repetitive phasic contractions in the abdominal line, which aren't present in the vesical line, representing rectal contractions. And when you look at these more closely, you see the negative deflection in your PDET line. This is very obvious in this case, but sometimes when you just get intermittent rectal contractions and your baseline pressures are slightly higher, you can misinterpret these as detrusor overactivity in your detrusor line. Here you can see this very spiky presentation on your PVES line and your PDET line. And this is a pump vibration that occurs if you're filling very rapidly. It's the filling line transmits to the measuring line, and it disappears when you stop filling. You can prevent this with a pump guard. Here, two very common artifacts, catheter flush. So here you're going along in the PAB line. The subtraction isn't complete, so the urodynamicist has flushed the rectal catheter on 2 occasions with a subtraction in the PDET line. That's fairly obvious. And here all 3 lines have had sudden movement, and basically the catheters have been knocked. Loss of catheters is also a fairly common thing that happens. Here we've got a PAB line. We get a nice rectal contraction with a corresponding negative deflection in the PDET line, and then the rectal catheter is actually passed. And likewise during voiding, here the urethral line is passed during voiding, and you get this sudden drop in pressure. Uroflowmeters are commonly bumped. So here we've got Here we've got a nice smooth uroflow line together with a rise in pdet and rise in urine volume flow. And over here, we don't have corresponding features of rise in pdet and no change in flow volume. So this is in fact an artifact. So just in terms of troubleshooting, before you run your study, you need, like any surgeon, like any pilot, to make sure that everything's set up correctly. I'm sure this has been covered by the other speakers, but check everything's connected correctly set up, zeroed at the correct level, that your uroflow is attached using the correct density on your machine, because saline is lighter than contrast, and make sure that your infusion fluid's at body temperature. If it's too cold, it can precipitate detrusor overactivity. Looking at your PVES line, if this is too low, this is classically due to air bubbles, but can also be due to incorrect positioning. We've all placed catheters in vaginas, and it can even be clever enough sometimes to put them into a large ureter. Make sure that the catheter isn't kinked. When you put a urethral catheter into a child in a frog leg position and tape it along the leg, and then the legs are closed, the catheter can often kink. The catheter can be blocked by gel or mucus. And the thing to do is to flush gently. Don't flush too harshly. If you flush most transducers above 300 centimeters of water, you can actually damage them. If you get a dead signal, they're non-responsive. The catheter may be the catheter hole may be up against the bladder wall. And what you need to do then is actually fill the bladder a little bit and then start measuring. Sometimes you only have the luxury of a single lumen, for example, a suprapubic catheter, or one of your cystofix suprapubic catheters is blocked. And then you can actually use a single lumen study using a film measure cycle on a 3-way tap. So you would fill 10, 20, 50 mils, depending on your bladder capacity, and then switch your 3-way tap to measuring. That needs careful annotation on your study. What about PABD? If it's too high, firstly, again, check the position. Is this in a contracted anus? Is it in a wodge of feces? Have you just blown the balloon up too high and there isn't a good enough slit? And you need to release the pressure. If it's too low, you can flush gently. The children where you can get too low PABD are the neurogenic children who don't get good anal closure. And I've spent many a study standing there trying to keep the buttocks closed to get some good PABD. If your pdet is too high, you need to fundamentally check your PVES and PABD are correct in the first place. But it might be that your bladder is not empty and you have poor compliance. It might be that the child's in the middle of voiding, particularly the little ones, or that there is sustained detrusor overactivity. And of course, you can't have a negative pdet in theory, so you need to correct all of that. Running the study, remember to press record. Some studies, some machines actually need you to start the study and record. If you don't, you lose the whole thing. Make notes as you go along, because again, computers can crash, electricity can stop, plugs can be pulled out of the wall, and then you lose all your information. If your pump is having difficulties, check your clamp, your air inlet valve, your connections. Classically, the problem of the giving set being put in the wrong way around actually removes urine out of the patient as opposed to pumping fluid in. Check that the giving set is correct. The other common error is that the infusion finishes and you start pumping in air, and that compromises the measurement of your traces. Sanjay has already mentioned the correct rate. If you're looking for DO, make sure that you bring the child upright, because you're more likely to see DO in these positions. And if you get loss of compliance, stop your filling and see if your PVES settles to check that you're not filling too quickly. With the pressure flow study, If you're bringing the patient from supine to standing, beware fainting, particularly in the teenager who's very inhibited. We've seen that lack of privacy can result in inhibited voiding and heightened sensation. You might need to leave the room to help the child to do this. Don't move, knock, or touch the uroflowmeter. Don't block the meatus with tape. And don't include knocking artifacts in your report. Good, thank you. I hope that's useful, and I'm happy to take any questions.